So, hi everyone, I hope you are all doing well. So, I'll be going through some short cases in this particular video, and I would like you to answer first, and then I'll give you a brief answer for all the questions. Mm, this is a video that I had made while preparing for this particular exam. I'll be making more videos in future if I get a good response for this, and uh, I hope you like it. Starting with the first case where we are provided with a frontal radiograph of a skeletally immature patient who is presented with the emergency department with irritability. So here we can see that on this particular view we cannot appreciate much, but on the lateral radiograph we can see there is a small bony fragment anterior to the lower tibia. So it's a case of a metaphyseal corner fracture or a classical metaphyseal lesion, which is very specific to non-accidental injury, particularly in less than 2-year old, particularly because of shaking. And in such cases, we need to immediately inform the pediatrics team or the treating physician and inform the safeguarding services within 24 hours and get a skeletal survey done for the patient. And if the patient is less than 1 year old, that is infant, we need to get a CT brain done as well. And in case of 1 to 2 years, the guidelines specify CT head only if there is some external injury or some neurological sign, but skeletal survey is a must. And as radiologists, we also need to uh, if there is a positive finding in CT brain, that is in case of subdural hematoma, we can see some bridging vein thrombosis or some hypoxic injury is suspected. In such cases, we'll also go ahead and get an MRI brain as well as spine done within 3 days, and it has to be followed up with a follow-up skeletal survey of 10 to 14 days later, and also the sibling in the house has to be imaged with the same protocol. So non-accidental injury is a very important case in RCR exam, and you need to know all the presentations, and raising suspicion of NAI is very, very, very important, and it's a pass or fail for the exam. So coming to our next case, where we are provided with a frontal radiograph of abdomen of a premature neonate. First thing to be commented on is lines and tubes in any radiograph. So the NG tube tip is in satisfactory position in the stomach. We can see that there are multiple dilated bowel loops in the central part of the abdomen, and a very important sign called Wriggler sign, that is gas outlining inner as well as outer wall of the bowel, which is indicative of pneumoperitoneum, which is a urgent finding and needs to be informed to the pediatric surgical team immediately for surgical intervention. Other complications of this particular condition, that is necrotizing enterocolitis in a premature neonate, is pneumatosis intestinalis, which is gas within the wall of the bowel loops, which is particularly seen in the right iliac fossa. Also, look for branching lucencies in the liver, which is indicative of portal venous gas. And if there is lungs also covered in the radiograph, look for respiratory distress syndrome. Always comment on the hernial orifices if there is some abnormal bowel protruding through the hernial orifices. So coming to another radiograph of a neonate who's presented with abdominal distension and difficulty breathing. So as I stressed upon in the previous case, the first thing to be commented upon is lines and tubes. In this particular case, the answer comes via the lines and tubes. We can see that there is a endotracheal tube, and then there is a tube with holes in it, which is actually a Replogel's tube, and a Replogel's tube is inserted only in case of esophageal atresia. So here our knowledge of lines and tubes helps us, as this is a case of esophageal atresia, and as we can see that there is a distal gastric bubble, we can conclude that there is an associated tracheoesophageal fistula. So esophageal atresia with tracheoesophageal fistula, and since there is no gas post duodenum, there is double bubble sign, giving another associated condition, that is duodenal atresia associated with it. Along with it, there are few specks of calcification in the abdomen, which is suggestive of meconium peritonitis, and there is opacity of the right lung, which is in case of premature neonate indicative of respiratory distress syndrome, and its asymmetricity indicates that it's post-treatment of surfactant. We also need to look for any associated bacterial anomalies, any vertebral segmentation anomaly, and raise this particular question with the surgical team, and discuss the further line of management with the pediatric surgical team. So this is a case of esophageal atresia with tracheoesophageal fistula, duodenal atresia, meconium peritonitis, and respiratory distress syndrome, and everything started with our knowledge of lines and tubes. So coming to another case of a premature neonate who is presented with signs of sepsis. So as now you have understood the importance of lines and tubes, let me get another case of lines and tubes here. Here again, commenting on the ET tube first, which appears adequately positioned, and the NG tube also appears to be positioned adequately in the stomach. There are another two tubes here which are very, very important in case of neonates, that is umbilical arterial and umbilical venous catheters. Umbilical arterial catheter always bends down and then goes up because it passes from the umbilical artery to the internal iliac artery and then to the aorta, and is typically positioned high up at T8 T10 level or L3 L5 level. The major risk factor is renal artery thrombosis. It needs to be avoided. Hence, either it is placed up or down to the renal artery origin. Second comes the umbilical venous catheter, which goes right up to the cavoatrial junction. Since it's placed here, the tip is here, and surrounding it are some gas air lucencies in the liver. It is supposed to be in the cavoatrial junction, but since it's here somewhere in the portal vein, it's causing some complication here. So common complications of misplaced umbilical venous catheter include hematoma or a TPNoma or a hepatic abscess formation. So in this case, as the inflammatory markers are raised, would suspect hepatic abscess formation or a TPNoma because of the misplaced umbilical venous catheter. So urgent information to the pediatric surgical team for drainage and antibiotics is important here. So coming to another interesting case of a chest radiograph of a skeletally mature patient who's presented with cough and chest pain. So here we can see that there is diffusely increased reticular markings throughout the lungs, and there is blunting of the right CP angle indicative of mild right-sided pleural effusion as well. So here you would go in lines of fibrotic lung disease, but here your observation skills are very important, as here you can see that there is a stent that is placed. It's a esophageal stent, and this particular patient has a esophageal malignancy for which the stent has been placed, and in this case these fibrotic changes were because of this malignancy. That is, it's a case of lymphangitis carcinomatosis because of esophageal malignancy. So lymphangitis carcinomatosis is most commonly because of breast malignancy and followed by lung and then stomach. So in this particular case, it's because of this esophageal malignancy, and you need to just be observant in this case to detect it. Always in RCR exams, a very important thing. If you get a finding, look for the cause of the finding in the same radiograph. So we need to inform this to the oncology team and compare with the previous radiograph and then move forward. So coming to the next case, which is relatively simple, where we are provided with a frontal chest radiograph of a skeletally mature patient who's come with chest pain, where we can see that there is enlargement of bilateral hilar lymph nodes, and as such we do not see any consolidation or reticulations or pleural effusion in the lung parenchyma. A very important finding other than that is that we can see there is a prominent pulmonary artery notch, which is suggestive of pulmonary artery hypertension, which can be a complication of pulmonary sarcoidosis. So do not have the satisfaction of search. Always try to look for uh, all the findings. So it's a case of pulmonary sarcoidosis stage 1, as there is no lung parenchymal involvement. Serum ACE levels for correlation, and pulmonary MDT discussion for further management with steroids is required. Coming to the next case, where we are provided with a frontal chest radiograph of a 25-year-old male who was presented with chest pain. So important finding to be picked up here are these particular paraspinal masses in the retrocardiac region, which is bilaterally present. Along with that, we have to always look for associated findings to look for any cause of this particular mass lesion. So here we can see there is expansion of the posterior ribs along with coarse trabeculations. So this is probable case of extramedullary hematopoiesis. And another important clue here is there is displacement of the bowel loops, the left hypochondrium, because of enlargement of the spleen. So there is splenomegaly, there is coarsened trabeculation of the bones along with paraspinal soft tissue, which is all due to extramedullary hematopoiesis, likely secondary to thalassemia, and it will require hematological referral and further management comparison with previous radiographs as well. Now coming to the next case, where we are provided with a frontal chest radiograph of a 50-year-old patient with minor cough. The striking abnormality here is there is sclerotic posterior right seventh rib, which is mildly expanded with thick cortices. There is no destructive lesion or any fracture that can be seen here. The lungs appear unremarkable and the cardiomediastinal contours appear normal here. There is no effusion as the CP angles are clear. So this in this particular age group would most probably be Paget's disease of the rib, and comparison with previous radiographs and MDD discussion for further line of management with bisphosphonates and analgesics is required here. So Paget's disease is a very uh, important disease that comes in RCR exam. All the presentations of this particular disease should be known, even in nuclear medicine. So next we see another very common case that is asked in the RCR exams, where there is a frontal radiograph. 15-year-old patient was presented with cough. Here we can see a potacath with its tip in the cavo-atrial junction, which is satisfactorily positioned, and there are ring shadows and tramp track opacities throughout both the lungs, particularly in the upper zones. There is no consolidation or pleural effusion, which is very important to comment on. So it's a case of cystic fibrosis which requires a long-term antibiotic therapy, and hence this potacath. So potacath can be put in case of malignancy where there is long-term chemotherapy that is required, and also long-term antibiotics where it is required, as in case of cystic fibrosis. You have to look for other complications like distal intestinal obstruction syndrome or secondary infections, fatty replacement of pancreas. The dietary changes uh, have to be put in place, and also comparison with the previous radiographs as to progression of the disease and pulmonary MDT discussion. So coming to the next case, where we are provided with a frontal chest radiograph of a skeletally mature patient presented with chest pain. You need to be very observant here to pick up all the findings here. Important finding here is linear densities in the right upper zone. No evident consolidation. There is blunting of bilateral CP angle suggestive of mild pleural effusion. There is retrocardiac opacity along the course of thoracic aorta, suggesting a thoracic aortic aneurysm. A very important finding here to be picked up is there is post vertebroplasty of L1 vertebra with vertically oriented cement extravasation in the paravertebral vein. So this important finding gives away the diagnosis of cement embolism, leading to acute chest pain and urgent referral to the uh, medical team or the pulmonary medicine team is required in this particular case to manage this particular case. So coming to the next case, where we are provided with radiograph of the right hip of a skeletally mature patient coming with pain in the hip joint, and the important finding here to be picked up is that there is a lesion along the cortex of the right superior pubic ramus, which as such does not contain any lucent nidus within. So diagnosis of osteoblastoma first and then a differential of osteoid osteoma can be given in this particular case. Important finding here can be picked up by looking out of the hip joint and into the superior pubic ramus. So all the corners of the radiographs and all the uh, bones in the radiographs which are present should be evaluated to look for any finding. That's how the exam tests you. So this will require a bone MDT discussion and further line of management accordingly. Coming to the next case, where we are provided with the frontal radiograph of a foot of a 65-year-old patient who's come with swollen foot, where we can see that there is an ulcer projected over the third toe metacarpophalangeal joint. Along with that, there is subluxation and periarticular osteopenia and destruction of the second and the third MTP joints. There is no evident vascular calcifications. So these constellation of findings are suggestive of septic arthritis from direct infection from the ulcer. Of course, diabetes has to be excluded in this particular case, and then MDT discussion has to be done to find out the cause and treat accordingly. Coming to the next case, where we are provided with a frontal radiograph of the spine of a patient post-trauma, where we can see that there is a reduction of the height of T12 vertebra along with a fracture line and a kyphotic deformity. The important point here is to see that fracture line extends through and through the vertebral body along with involvement of the posterior element, and there is interspinous widening. The spinous process is not very well visualized on this AP radiograph. The very important finding here is to pick up that the posterior element is involved by the fracture line, hence causing a chance fracture, which is an unstable fracture, and immediate referral to the orthopedic team for MRI of the spine and CT of the spine to assess for the extent of involvement and what other structures are involved and the extent of spinal cord injury. Also, we have to look for any associated retroperitoneal structure injury like duodenum or pancreas, and manage this patient according to the trauma protocol. So another trauma case where we are provided with supine chest radiograph of a skeletally mature patient, and here the findings are quite obvious. There is a deep sulcus sign on the right side, which is indicative of a pneumothorax on the right side, and an immediate surgical referral is required for this case. Trauma protocol again has to be followed here to look for any other associated injury, and the management has to be done accordingly. Now coming to another important trauma radiograph, this frontal chest radiograph taken in supine position demonstrates increased mediastinal width. There is mediastinal widening as well as depression of the left main bronchus and opacity in the left hemithorax. All this is suggestive of aortic injury or aortic transection with mediastinal hematoma, and this being a supine radiograph, this is a left-sided hemothorax. So it's a surgical emergency, immediate referral to the cardiovascular team as well as the emergency team for stabilization, and a CT angiography followed by aortic stent graft repair has to be done here. So coming to another chest radiograph of a 50-year-old male patient who has come with chest pain. So another important radiograph where the constellation of findings leads to one particular diagnosis, as we can see that there is depression of the end plates here. Multiple end plates, central depression is seen, giving a H shape. So this is H-shaped vertebra. Along with that, we can see that there is sclerosis in the heads of the humerus, suggesting avascular necrosis, and instead of the splenic shadow, there is bowel gas indicating autosplenectomy. All these findings indicate underlying sickle cell anemia in this particular patient. Hematological referral and further management is required here. Coming to a shoulder radiograph post road traffic accident of a skeletally mature patient where there is disruption of the Moloney's line as well as the loss of the half moon shape overlap along with a fracture this line in the anterior aspect of the humerus head, which is suggestive of a trough line sign. It's a posterior dislocation of the shoulder with trough line sign. Immediate referral to the orthopedics team for further management and MRI is required. Coming to another important radiograph of the knee joint of a skeletally mature patient who's come with injury while playing football. At the initial look, this looks apparently normal, but as you trace the femoral condyles, the lateral femoral condyle has a depression here. It's called the sulcus terminalis impaction injury, which is commonly associated with ACL. Hence ACL tear, and hence MRI of the knee is required in this particular case, and this needs to be picked up and informed to the orthopedic team for further management. Coming to another radiograph of a hand of a 55-year-old female patient with hand swelling. So there is extensive soft tissue swelling as well as solid periosteal reaction, all the visualized bones. and this is indicative of thyroid acropathy. This is actually a spotter, and previous imaging and along with thyroid function tests and neck ultrasound would be required for further management, and endocrinology referral would be done in this particular case. So coming to another common radiograph, where we are given the radiograph of a lower limb of a skeletally immature patient coming with bowing of the legs. Obvious is tibia vara along with medial cortical thickening, and there is fragmentation, depression, and beaking of the medial tibial metaphysis and increased metaphyseal diaphyseal angle, which is all suggestive of Blount's disease. In this case, we will also compare it with the other limb and refer this case to the pediatric orthopedic team for further management and osteotomy. Now coming to this particular foot radiograph, which just tests your observation skills. We have looked for fractures everywhere. There is no fracture here. There is mild calcification seen along the medial aspect of the foot, which is actually a calcific tendinosis of tibialis posterior. So this is checking the anatomical knowledge as well as observation skills. And then orthopedic referral is required for further management. Now coming to our next case, where we are provided with a frontal chest radiograph of a 1 month old child with acute shortness of breath. So in this particular radiograph, it's a very important radiograph for the exams, where we can see that there is overinflation of the left lung as well as increased lucency on the left side, and there is shifting of the mediastinum towards the right. In case of acute onset of dyspnea, the only thing that should come to mind should be a foreign body within the bronchus, and urgent referral to pediatric team or the referring physician for bronchoscopic removal and follow-up radiograph has to be done. Now coming to radiograph of the wrist post-trauma, where we can see that there is fracture of the scaphoid as well as carpal dislocation, that is perilunate dislocation, as the lunate is aligned well along the line through the shaft of the radius, but the other carpal bones are dislocated posteriorly, which is suggestive of perilunate dislocation. So it's a transscaphoid perilunate dislocation. Urgent referral to the orthopedics team, and follow-up radiograph has to be done for the same. So another important radiograph of a 20-year-old female patient with right leg pain and swelling, where we can see that there is an aggressive periosteal reaction along the shaft of the fibula, and there is a sclerotic lesion with a wide zone of transition, and along with that we are seeing a soft tissue associated with this. This is a very important radiograph which is indicative of a neoplastic etiology, and this particular age group, it is most likely a Ewing sarcoma. Urgent referral to the pediatric oncology team and the bone tumor MDT for further discussion, and MRI needs to be done involving the joint above as well as below to look for any skip lesions, and a staging CT has to be done for the same. So another important radiograph of a foot of a patient presenting with injury. Two important things we always should look at a EP projection of the foot is the talofibular overlap, which should be more than equal to 6 mm, and the medial joint space, which should be less than 5 mm normally. Other than that, we look for any fractures in the provided sections of the tibia and fibula as well as the tarsal bones, and here we can see that there is a osteochondral defect or a fragment seen on the lateral aspect of the dome of the talus. A referral to the orthopedic team for further management is required in this particular case. So learning from the previous radiograph, another case of injury, we can see that there is reduced tibiofibular overlap as well as increased medial joint space, which is all indicative of some ligamentous injury within the ankle. There is shifting of the talus laterally. We need to also get a radiograph above this particular level to look for any proximal fibula fracture to rule out Meusonius fracture, and raise the possibility of the same, and get MRI of the ankle done to look for any ligamentous injury. which is very likely in this particular case. Coming to the elbow radiograph of a 6-year-old patient who's presented with pain, we can see the anterior humeral line is not intersecting the middle 1/3 of the capitulum, which is suggestive of a supracondylar fracture. Along with that, there is mild elevation of the anterior fat pad, which is suggestive of a sale sign seen in joint collection or hemarthrosis. Urgent referral to the orthopedics team for further management is required. Another important pediatric radiograph commonly asked in the exams, where we can see that we can get to this diagnosis by remembering CRITO, that is the ossification center of capitulum is present, radius is present, internal epicondyle is not seen in its position, it is actually displaced here into the joint space. Trochlear's ossification center is present, as well as lateral epicondyle ossification center is present. Olecranon we cannot see, we have to look at the lateral radiograph for it. So there is avulsion of the internal epicondyle ossification center here into the joint space, which is urgent finding, and we need to urgently inform the orthopedic team for the same. So it's a relatively simple case of a triangular avulsion fragment at the extensor aspect of the distal phalanx at the DIP joint, which is suggestive of mallet finger, and orthopedics referral for further management is required. Coming to another important case of a 65-year-old female patient with chest pain, we can see that there is a large mass, elongated mass along the mediastinum, and the cardiac borders are very well visualized, and we can see that this mass lesion has air fluid levels, and it is seen extending from the neck down up to the gastroesophageal junction, which is all suggestive of achalasia cardia, and referral to gastroenterology team for further management will be required, comparison with previous radiograph, and CT if required.